In this video, we would see the technique for inside-out medial meniscus repair. We start the diagnosticoscopy by probing the ACL, which looks to be normal. The fibers are intact. After this, we will be proceeding for seeing any tears in the ramp area of the medial meniscus, for which I would show you the modified Gilchrist technique for reaching the posteromedial corner of the knee. Here we put the scope without the sheet from the medial portal and advance the sheet along with the trocar in the posteromedial corner, and then remove the trocar and insert the scope to see for any tears. As we can see, there is no ramp lesion or any capsular rent seen here. We come back into the joint to see for the tear in the medial meniscus. Here the posteromedial aspect of the meniscus is probed in valgus and extension of the knee so as to make some space for the probe to go inside. If the space is still tight, you can do pie crusting of the MCL. Here we are able to feel the rent on the under surface of the meniscus with a probe, and it can be hooked into the joint. With a shaver, we now freshen the edges of the tear, so we have good end-to-end healing of the meniscus tissue. I personally like to do some trephination of the torn edges so as to improve healing response of the meniscus. For this inside-out repair, I am using the Arthroscopic Protector Meniscus Suturing Set. It comes with a needle, a cannula. The needle is devoid of any fiber wire. Instead, it itself has a loop through which a 0 number or a 20 fiber wire can be passed. So the needle technically can be used for many passes along with multiple fiber wires. So the construct becomes cost effective. The cannula has a curved tip so that you can position it easily inside the joint. Also, the cannula is flexible throughout its length, so you can give it the shape you want to reach a particular part of meniscus. So this kit makes my repair universal without using multiple zone specific cannulas and separate needles on fiber wire. Here I have positioned the cannula for the first bite near the posterior most part of the tear towards the posterior horn of the medial meniscus. Once the bite is taken, I prefer vertical mattress configuration, advance the needle towards the capsule and take the pass through the capsule. The needle is withdrawn on the outside over a spoon which is inserted through a posteromedial safety incision. Also, once you have directed the cannula posteromedially, the needle exits through a safe zone because the neurovascular bundle lies posterolaterally just behind the septum. Here we are taking the second bite, again vertical mattress fashion, using the same needle but a new 0 number fiber wire. We are taking 2 bites on superior surface. The last stitch is taken on the inferior surface so as to balance the repair, otherwise the meniscus will turn upwards once you tighten the sutures. For the third bite, I have taken a 2-0 ethibond to save on cost. With a little bit of care while passing it through with the needle, we avoid breakage of the suture and hence reduce the cost of repair. Again, the stitch is taken in vertical mattress fashion. First stitch on the under surface of meniscus, then the cannula is passed below the meniscus and the second stitch is taken through the capsule. After all the sutures are retrieved from the posteromedial safety incision, I proceed with knot tying. I use SMC type sliding locking knot to seat the knot because the sliding knot nicely locks the meniscus in place to avoid any residual slack in the repair. Here we can see the 2 vertical mattress type superior sutures which have placed the meniscus nicely, and the 1 inferior suture which has balanced the meniscus so it doesn't upturn once we have tightened the suture, and meniscus has regained its normal configuration. Thank you for watching the video.